Good afternoon, ladies and gentlemen. Welcome to the FIN Prostate Health Education Network monthly webcast. Tonight, our subject is prostate cancer clinical trial opportunities and understanding the possible benefits. I want to make sure that I welcome everybody here in Boston to this meeting. We've been here since many years, since 2003. And I also want to welcome all of those who have tuned in to join us tonight in Cyberland, wherever you may be. We're happy to have you with us this evening. I always like to start this program by thanking our partners and sponsors, and you can see some of them there. They make what we do possible. They help us educate and provide materials to our audience constituents around the country. So thank you to our partners and sponsors. And I want to also make everybody aware that this is not just a broadcast, so it's not like television, it's a little bit more. So if you want to join in to this program at any point, you can simply email us a question, or you can send it to us on Facebook, or you can tweet it. And once the presentation is completed, then we will go to those questions and you will join in. You will hear directly your question answered. So please join us, and we'll make this a very fun event. Now, tonight, our presentation is by Dr. Jacques. Those of you who have been with us over the past few years, we know Dr. Carter. Dr. Carter is a member of the Finn family. He is he's assistant professor at Harvard Medical School. He's our medical advisor, and Dr. Carter has been working with Finn since we began our outreach activities way back in 2003. So I have a bio here for Dr. Carter. It's hard for me to read the bio since I have such a close relationship with him. But Dr. Carter currently serves as a senior physician at the Beth Israel Deaconess Medical Center in Boston, and is an assistant professor of medicine at Harvard Medical School. He also serves as a medical director of the prostate cancer screening and education program at the Dana-Farber Cancer Institute, where we are this evening. He has earned degrees from Howard and George Washington Universities and received his medical degree from Georgetown University, all in Washington, D.C. Dr. Carter completed his residency training in internal medicine at Beth Israel Deaconess Medical Center in Boston, followed by a graduate program at the Harvard School of Public Health, where he received his Master's of Public Health degree. He then completed a clinical fellowship program in primary care medicine at Mass General Hospital. And Dr. Carter is very active in many community and civic activities. He's, in addition to being one of our advisors, Dr. Carter is just an outstanding individual. I think that's the best way to sum up Dr. Jacques. And we're fortunate to have him with us this evening. Now, if I can get this to work the way it should. Dr. Carter, let's give Dr. Carter a round of applause as he comes forward as I make sure that we get this done. I'm going to turn this over to you, Dr. Carter. Yeah, I've never had this. There we go. Thank you.
Good evening. Good evening. Good evening. It's a wonderful day to be in Boston and have discussions about a topic that is near and dear to all of us in this room, prostate cancer. And as Tom mentioned, today's program is pretty much about some clinical trials. Now, over the course of the past 3 or 4 months, we've had a lot of discussions about clinical trials, about different phases of clinical trials, how they're put together, some of the pros and cons of clinical trials. And today, we thought we'd talk a little bit about 3 or 4 clinical trials. And then at the end of that, I'm hoping that you will have some questions about what we spoke about. So, as you know, and one reason that we're having this rally, Defenders having this rally about clinical trials, is that a lot of African American men just don't participate in clinical trials, and there's a big disadvantage up to doing that, and that is that when it comes to treatment of various kinds of diseases, cancers and non-cancer diseases, heart disease, diabetes, and other things, decisions about what works for us as African Americans are generally made on clinical trials done in people who are not African American. And it's not always fair because there may well be genetic differences that means something works for us a little bit different than somebody else. And the only way that we can sort of find out if something works for us is to be participants in the clinical trials. There are genetic differences, we know about those, there are lifestyle differences, a lot of things that go on that make it very important for us to participate in these trials. Of course, people say, well, why don't blacks participate in clinical trials? Well, a lot of you know the answers. There's always an issue that we are the subject of experimentation. In my practice, I'll have patients often ask me, don't send me to a doctor who's going to experiment on me. And that's a throwback, as a matter of fact, that people think that when you go to see the doctor now, you go to a teaching hospital, you go see residents, they're experimenting on you. Now, you know, that's a hard word because they're learning on you. And to some people that is experimentation, but it's not the same as the old situations where we were the subject of trials that we had no control over. And many of you are certainly aware of the Tuskegee experiment. I don't have to tell you about that. That's you know, the literature is full of information about that, about how African American men in the South were diagnosed with syphilis and weren't treated. And it's one thing to not be treated when the treatment was not available, but they didn't even get treated when treatments became available, and were not told completely about what was going on. And I think a lot of the distrust about clinical trials for us comes from some of that old history going back. We had a presentation here a few months ago by a young scholar who gave a long discussion about medical experimentation in blacks and slaves, which were done, basically they had no control over that. But even after slavery was over, there were a lot of things going on in places in this country and some highly regarded medical institutions that we would not tolerate today. So we just need to be included because it leaves a significant void in our treatment options if we don't get included in these clinical trials. Treatment options. So you develop a condition, you sort of want to find the best treatment. The only way you're going to get the best treatment is to know what works. And how do you know what works? Clinical trials. Every medication, almost every medication that any of us takes today was tested with a clinical trial. Somebody took the medicine to see if it would hurt them. Those people in that first group had no benefit. There was no benefit to the first group of people who takes the medicine. But every day in this country, somebody's doing a clinical trial, phase 1, where they're being given medicine just to see how toxic it is. There's no benefit. You sign up for that knowing that there's no benefit. Okay? But the idea is that if you can tolerate the medication, then you go into clinical trials where the possibility of some benefit is there. And that's a real possible benefit. Basically, if you get in a clinical trial, you know, what are some of the benefits? Well, one big benefit is that you get a chance to get something before everybody else has a chance to try it. You know, that cuts both ways. You know, if there are a lot of bad effects to the treatment, and you're on the front end of that, you know, and all of a sudden people say, I don't want that because, you know, I saw what happened to my friend who was in a clinical trial. But if you are in a situation where you need some special treatment, and the standard treatments have failed, then you're looking at other things. And that's where a lot of clinical trials come in. You want to find out what is going to be the best treatment. What is the next best thing, the next best treatment? What's the next best cholesterol pill that works 10 times better than the ones that are out now? The next diabetes medicine, the best insulin, the best heart medicine, and of course the best cancer treatments. Always cancer treatment, because a lot of cancer treatment has been experimental. So what I'm going to do is go through 3 or 4 clinical trials, so-called phase 3 clinical trials, where people are enrolled and are being treated. And keep in mind, as I said before, and you know this, is that you have to be offered the best available treatment. There's no clinical trial that avoids you getting the best available treatment. Okay? That's a standard protocol and a guideline used all over this country. I cannot offer you something that I know is not at least as good as the best treatment available. This is the EMBARK trial. It's a trial for patients with a rising PSA after being treated with surgery and radiation development. So why would a patient have a rising PSA? Well, in most cases, there's a recurrence of the cancer. You treat the cancer, PSA drops, sometimes to undetectable, and lo and behold, a year later, 3 years later, 8 years later, the PSA starts to rise, and we know from that the only cells that are making this PSA are prostate cancer cells, or prostate cells, and if you've taken out the prostate or zapped it with radiation, and you start to get a rise, it's an indication that there is a recurrence of the cancer. So this particular trial, patients are randomly selected and assigned to a group to either receive Xtandi, which is a medication called enzalutamide, plus Lupron, which is an anti-androgen. It's a medication, a hormone that we use standard of treatment for people who have recurrent cancers, metastatic cancers. So here's a standard, Lupron, standard, been around for a long, long time, as a way to block the impact of testosterone or androgens on the growth of cancer cells. And here we're taking Lupron plus Xtandi, enzalutamide, another medicine that works in the same area, and to see if it works better than Lupron plus placebo. So here's a case where the patient, unbeknownst to him, is either getting Lupron, which is a shot, and enzalutamide, which is a pill, or Lupron, the shot, and a placebo. Now, is there anything wrong with this particular clinical trial? Can you see anything wrong with that? The person is actually getting the standard of care, which is the Lupron. So the person who, in fact, is getting the placebo, the sugar pill, not the medication, is still getting the higher standard of care, as we know it. And the whole idea of the clinical trial is, do we get better treatment with the addition of Xtandi to the Lupron? Benefits: increased time before prostate cancer spreads. So the whole idea is to try to hold down the cancer with this new treatment. And in doing so, we extend the life of our patients. Possible risk: doesn't work. Or maybe for some reason, with the standard of care, Lupron, and the addition of the Xtandi, maybe the Xtandi takes something away from the benefit of Lupron. How are you going to know that? You don't unless you do the clinical trial. Xtandi is a pill, Lupron's a shot. It's easier to give a placebo in a situation like that, because the placebo can be made to look just like the Xtandi pill. And there's no way that the patient can tell which he's got. And a lot of times these are double-blinded studies where the doctor doesn't even know which one you got. Okay. The key has to be broken at some point at the end of the trial to see which combination you got. And what that does, of course, is it takes away any subjectivity about doing an analysis of the clinical trial. If I'm the treating doctor, the guy who's running the experiment, and I've got patients I'm giving Xtandi and Lupron, and other patients that I'm giving the placebo and the Lupron, I may sort of be subjectively pushed towards thinking, well, gee, I know he's getting the Lupron and the Xtandi, and I think he's doing better. I think he's doing a little bit better. And so there's a little bit of subjectivity to how you do that if you know what somebody's getting. Pretty easy to say. Something is better if you know what's going on, and that is not always objective. And one thing about clinical trial, we have to be super objective in how we look at it. So it's very, very important that these studies be blinded so nobody knows what's going on until the very end. This particular trial is done by Medivations, Inc., which is the Pfizer company, and it's an ongoing clinical trial. Now, it's important that if you're in this category and you have an opportunity to participate in a trial like this, and you're African American, you want to look into it. We would encourage that, and FIN supports that. There's another trial called the ENACT trial. Now, this is special. This is for patients considering active surveillance or currently undergoing active surveillance. So active surveillance is where you've been diagnosed with a low-grade cancer, and you've decided that you do not want any definitive treatment. It's low-grade and may not bother you over the course of decades, and you can avoid any potential adverse effects of treatment. So we call that active surveillance. You always want to sort of feel that you can keep people in a category where they can be actively surveilled over a longer period of time. But we know for a fact, as we monitor people on active surveillance, that some of the men develop more advanced cancer. Things happen. The cancer spreads. Or you go and do another biopsy in a year or so, and you end up with more areas that has cancer. Or the grade of the cancer changes. So it goes from a Gleason 6, a very sort of low-grade cancer, to maybe a 7, maybe even an 8. And it alters how we look at the treatment options. So you can no longer actively surveil that person. At least that would not be recommended. The recommendation would be to treat that person with either radiation or surgery if you can do that, or radiation, or some kind of chemotherapy. A lot of options, but you can no longer actively surveil a person who has started to develop an aggressive cancer. So if you have medication that may keep that person in that low-grade category, then that sounds like a big plus, right? And that's the nature of the ENACT trial. Patients are assigned randomly, again, by chance, to a group to receive the drug Xtandi, or to a group that will undergo active surveillance. And the feeling here is, does Xtandi keep a certain group of men in the active surveillance category? And at the end, you look at how many men in the group went on to develop more aggressive cancers versus the men that didn't. And if this is an effective treatment, then the Xtandi group would have a lower number of men going on to worse grade of cancer. Possible benefits, again, preventing or slowing the progression of prostate cancer. Everybody is, of course, closely monitored in these clinical trials, looking for progression. And, of course, that's being done in a case like this with PSA testing and, of course, imaging and biopsies to make sure that nothing's changed. Possible risk, if Xtandi doesn't work any better than being on active surveillance. That is that at the end of the study, both groups look the same. If that is the case, then Xtandi did nothing for these men. And what's the risk of that? Well, the risk is that the guys got Xtandi and didn't need it. And all the potential side effects of medications like this, which can be headaches, weight gain, constipation, diarrhea, depending on the person, back pain, and on and on and on. These are all potential adverse effects of some of these treatments. But the benefits outweigh the risks in most cases, and that's why we do these clinical trials. This is done by Stellus Pharma, which is a FIN supporter. Now we got another one. We got all these names, Embark and Atlas, and so when they get some of these names are sort of made up from initials. So they put together these sort of acronyms and everything. Anyway, this is a clinical trial for patients diagnosed with the high-risk, localized, or locally advanced prostate cancer as determined by their PSA and or the Gleason score in the cancer stage. So, high PSA greater than 10 or 20. Gleason score generally greater than 7 or greater. And cancer stage, that means there's evidence of some extension of the cancer. So these are the men, these are high-risk guys who, if you don't treat them, will end up with widely metastatic disease in most cases. So these patients are randomly assigned to a group whose treatment is a combination of experimental drug, ARN 509. It's called apalutamide, so it's very, very close to enzalutamide, which is Xtandi. And they get this plus hormone therapy plus radiation, or the other group that just gets hormone therapy plus radiation. And again, the radiation here is to slow the growth of the cancer by blocking the receptors on the cancer cells so that the cancer does not spread. And the radiation, of course, is to kill the cancer cells. And hopefully the two things together will decrease the cancer burden. And hopefully this new medication, the experimental medication, ARN 509, will help slow down any kind of growth. Again, benefits to the patient. It always has to be a benefit. Presumed or planned benefit. Reduced potential for spread of the prostate cancer following primary radiation treatment. Possible risk, combination, doesn't work any better than hormone alone, and you've exposed the patient to a medication that may cause some systemic side effects. Again, most of the side effects are things that I mentioned: headaches, fatigue, weight loss, peripheral edema, swelling of the legs and feet, back pain, loss of appetite, things like that. These things go away when you stop the medications. This is a Janssen Oncology Group, Aragon Pharmaceutical clinical trial. We have this. What can be bigger than Atlas? Type. This is the type clinical trial. And again, this is with ARN 509 or apalutamide. And it's also another Aragon Pharmaceutical trial. This trial for patients with prostate cancer that has spread to their bones, but hormone or so-called androgen deprivation therapy still keeps the PSA low, right? So we know they've got bone cancer, but the PSAs are low. That means that the hormone therapy is holding the PSA in check, holding the cancer cells in check. Right? So here, patients are randomly again assigned to a group for treatment with a combination of the drug and FDA-approved hormone therapy, or to a group with placebo plus hormone therapy. And here's a situation where you'd like to sort of see if this particular hormone plus this new drug would do better than the placebo and the hormone alone. Possible risk: the combination of hormone therapy and ARN does not work any better than hormone therapy alone. And again, these men would be exposed to this medication. But keep in mind that these are stage 3 clinical trials. Okay, so we've already gone through all the toxicity stuff in one, and you've gone through, how much can we give the person that does some benefit, and now you're in real, honest to goodness clinical trials. These are done all over the world, multi-center sometimes, single center sometimes, and a lot of these trials don't work. They don't. You end up at the end spending a lot of money, if pharmaceutical companies do, and they come out and they say, well, we don't see any benefit. There's no difference. Okay, so in scientific jargon, the null hypothesis is that there's no difference between A and B. And so you do a test to see if you can find the difference. Because if you find that there is a difference, then it doesn't support the null hypothesis. So here's a situation where you've got treatment options with various drugs. Every one of the drugs that I mentioned, the enzalutamide, the Xtandi, the ARN, all of them have been approved. These are not experimental agents. They've been approved already for treatment. And so these clinical trials are being put together with medications that have already been approved. What we don't know is how they work together. Okay? So these are clinical trials, or experiments, if you will, but with medications that have already been approved by the FDA for treatment of cancers. Many of these, Xtandi and others, are given for castrate-resistant prostate cancer. This is where you've given the person has been treated, and the cancer comes back, and now they're on Lupron or some other androgen deprivation therapy, and that's not working, or they get bone mets, and the medicine's not working, and some of these medications come and help that. But if they can offer some benefit in situations of active surveillance, which I think is one of the biggest areas right now, the big question now is, how do you take men who have low-grade prostate cancers, who may not need anything at all, and keep them in that category? And there are a lot of clinical trials going on, or planned, looking at just that particular point. Can you take a person who's got low-grade cancer? We're not talking about the high-risk cancer, because all the high-risk cancer need to be treated. But you're talking about a low-risk cancer, a Gleason 6, or maybe even a 7, that is a 3 and a 4/7, that you can monitor in somebody who's otherwise healthy and maybe does not need any kind of extensive treatment. If you can find that, it'll be a great benefit. It's not the same as trying to prevent prostate cancer, but it allows a lot of men to be treated without surgery or radiation, and that's sort of the next step. You should talk to your doctor about these clinical trials. I get calls all the time that there's some clinical trial that somebody wants to participate in, not necessarily prostate cancer, but all kinds, heart, diabetes, and other things. And they have to be, the information has to be written in a way that you can understand it. Okay, it has to be done that way. They go to a board that wants to make sure that you understand what you're signing up for. But even with all that, I tell my patients to bring it in so we can talk about it. Look at it and see whether or not there's something in there that they may or may not want to do. And I think that's a fair thing to do. For information about this, you can certainly visit the fintrials.com for information about all the clinical trials, or the Fin webpage is all this information about these clinical trials. This is just 3 or 4 things that we talked about here, but there's so many, many clinical trials. And the Fin, of course, invites prostate cancer patients and their loved ones to join the Fin network so you can receive information about what's cutting edge in the area of education and treatment of prostate cancer. I just want to say that, again, clinical trials are protected, patients are protected a lot because of the Tuskegee experiment and all of the problems that went on with that. There have been huge changes. So we were on the forefront of that. Black folks were on the front of that, but changes were made in the way clinical trials are conducted that benefit all people, not just us. Cannot do clinical trials without going through special boards and a lot of regulations. And the whole reason for that is to prevent people from going into clinical trials where there's no benefit, where somebody's trying to figure out toxicity without you knowing that that's what they're trying to figure out. Now, when you go into a clinical trials, you see an advertisement saying, phase 1 clinical trial, you know that you are a first-class guinea pig. There's no doubt about that. They're saying up front, we want to know, is this bad for people? And they pay you well for it. And then some people will line up to do those clinical trials, you know, and they can sometimes be dangerous. But those are the trials that allow us to get medicine that go into, you know, phase 2 and phase 3. So I thank you for your attention, and I'm here to entertain any questions that you might have about clinical trials or anything else that you want to talk about. Yes, sir. Use the mic.
Yeah, Dr. Carter, I've been in and out of the hospital most of my life for different things. And I've never heard anybody ask me about a clinical trial and anything. So how do you know about these clinical trials?
Well, you know, we advertise them in our hospital. Most hospitals advertise them. Sometimes they get appropriate patients from list of diagnoses. So they will, somebody wants to do a clinical trial on a particular medication, they will say, I want to treat anybody who's had X. And they go into the computer and hit a few buttons, and they kick out all the people who had X.
Well, in the last 10 years or so, my hospital started asking people about it. But before 10 years ago, I never heard of a clinical trial.
Well, I mean, so some of that could have been bias on the part of the people doing the research. And you know, the bias is that, well, you know, he's a black guy, he's not going to participate in a clinical trial.
Yeah, that's what I was thinking.
You know, some biases, you know, so they sort of, and so they don't ask you to participate. But in doing so, it sort of leaves us out in terms of how effective a particular treatment might be. But there are a lot of clinical trials and a lot of areas going on, and this, right in the middle of this area here, which is the greatest research area in the world, somebody's doing something on everything. In some of these places, here, the med school, across the river at MIT, and all those research places in Kendall Square in Cambridge, there's just so much going on right now.
Well, I know my hospital where I go now, are they doing a lot of clinical trials on a lot of things now?
Yeah, yeah.
But up until about 10 years ago, I never heard of it.
Yeah, one of the big complaints that we often hear from folks of color, especially black folks, is that you know, when they start looking at the list of exclusions, who can't participate, you know, we get ruled out on a whole bunch of these clinical trials because well, you can't have hypertension, you can't have diabetes, you can't have this, you can't have that, all of a sudden, you know. So if you got any of these kind of things, you know, you're sort of ruled out of clinical trials anyway. So there's been some big pushes to try to include more people in some of these clinical trials that have some chronic medical conditions. But a lot of times they exclude that. They want people with nothing except that one thing, you know, because it makes for a cleaner clinical trial. You don't have to worry about the impact of the diabetes on the heart disease, on this, that, and the other. But it's not real life. It's not realistic. Yes, sir. Mike, please.
Well, Dr. Carter.
Yes, sir.
Testing 1, 2, 3.
That's all. I hear you.
For over 12 years. But as far as I am concerned, no. Like you were talking about, they ask you, do this through a phone interview, or you come in and you start telling them some of the other things you have. They say, well, our sisters. Yeah.
But women have been, you know, more willing to participate in clinical trials than guys anyway. You know, we guys tend to be a little bit suspicious. Sometimes we don't think we need the clinical trials, or maybe somebody else would do it. And what happens is it doesn't get done. Research Task Force 2012 guidelines were based on almost no black men being in the clinical trials. Out of, you know, scores of thousands of men. You could not see any particular change or trend for us. If there was one there, it would be just totally covered up by the majority population. So, you know, we need to sort of participate in that. And that not participating in that is not all our fault. It was done for a lot of the reasons you guys just mentioned. Yes, sir.
So, Dr. Carter, are you saying that they are at a certain point, and then they call you up and tell you, well, you're disqualified because you have this?
Yeah. As a rule, they're still pretty restrictive. What I'm saying is that you're starting to get more and more of these clinical trials, but as a rule, they're still fairly restrictive. And that is because the researchers want to hold things in check. Yes, sir. Mike?
Yes, thank you. Is the microphone on?
No. Give another one.
So my question is for patients that may be diagnosed and have not been offered to participate in any clinical trials, and they do the research on their own, and they find a clinical trial that interests them, do they need permission from their doctor to participate in that clinical trial?
No, you don't need permission from your doctor. You need to sort of go through the hurdles that the person running the trial has put in front of you. But you know, I don't have to give my patient permission. What often happens is this, because there's so many studies going on. You know, once a week, once every 2 or 3 weeks, I get an email. We're doing a trial on 85-year-olds or people who are 80 and over for diabetes or cholesterol or something, and we have this list of your patients who meet the criteria. Is it okay with you if we contact these patients about the clinical trial? And as a primary care doctor, I'll say yes, contact this person, or don't contact this person. He or she will not participate. And what I will, and I say that, sort of tongue in cheek, but I know that if I don't rule that person out. When I see that person next time, they want to know, why did I send these people at them with this clinical trial? So as a way I know my patients, and I sort of know who will participate and who won't. But we get those kind of lists all the time. And again, they're based on a particular diagnosis, a particular blood test. With all these computers now, we can go to the hospital and tell you anybody who had any diabetic who had an A1C greater than 11. You just pull the numbers up, and they might want to go look at those people, and they'll tease it out. They'll do some research, go through the charts, and they'll pull out some people they want to do a test on. You mentioned your wife participating in these women's studies. Well, these studies have been going on for 25, 30 years. The doctor studies, the nurses studies, the first big ones, and they're literally hundreds of thousands of people now with data. And that's where they get a lot of information about what you think works and what you think doesn't work. Does lycopene work for prostate cancer? Was selenium good? Well, they get that data from all this history they're getting from these guys who participate in these trials. And there's so many of them now, there's a lot of data. Now, one thing about getting that kind of data in these trials is that, the surveys actually get a lot of information, and is that sometimes you pull stuff out and you find out that, gee, these people over here had more than 4 cups of coffee a day, and these people had less than 2, and these people had better whatever, or they had less heart attacks. So maybe coffee is good for these people. Now, that's great, but that was culled from a lot of information that was not put out there to seek whether or not coffee drinkers had more or less, heart disease. It was just general data they pulled out and started teasing out and looked at the numbers. What you have to do in a case like that is now then go and do a prospective study where you're now looking at people who do certain things and going forward, because that's a better study. A stronger study when you start to put together a study, a trial on your own, and go forward, as opposed to doing retrospective information, going back and grabbing data that somebody else collected and saying, oh, look at what I found. These guys had this, these guys had that. So there are all kinds of ways to do clinical trials. Some of them come up with stronger data than others. But getting information and surveys, reliable information from people who say that they exercise 3 times a week, or they drink, 3 drinks a day, which is like, 21 a week, right, Larry? I'm not saying that Larry's just drinking 3 drinks a day. I just know he knows numbers. That's all. That's why I looked at that. But I think that there are things that you get when you do these kind of clinical trials, and when you get this kind of survey information, that sort of informs what kind of direction you want to go in with certain kinds of clinical trials. And because of that, so participating in those kind of surveys and being, and I have to be honest with you. I mean, I have to, put all my cards on the table. I get these things from hospitals all the time. You're a certain age, and we want to sign you up for this, and because I don't have time. I don't have time to do this. I don't have. And the truth is that we probably ought to do a lot of these things. And I have to be honest that the next one I get, I'm going to participate. And I'll come back and report to the group. Any other questions back there? Anybody else? Yes, sir. Mike, please. It's over here.
Well, I can talk loud enough.
No, but here's the mic. Here's the mic. Okay. We'll come back to you. Don't worry.
I'm on active surveillance right now, but so far everything is sort of okay, just being watched closely. What would be the triggering statistic that would mean that I would want to look for a clinical trial to do something different from what I'm doing now? For instance, would it be the acceleration of IPSA? Would it be a certain level of PSA?
Well,
would it be a microscopic change in the Gleason 6? What would it be?
What would be the impetus for you to jump into a clinical trial?
Exactly.
What you'd like to know is if one of these current trials shows that the guys who are active surveilled and who are being active surveilled don't go on and get more aggressive cancer, and how you're going to be a part of that. You could be on the forefront of that by joining one of these clinical trials. That's how you get out in front.
So not necessarily a precipitating factor, just really a curiosity about something that might extend my regime longer than it might be without it.
That's exactly. That's the whole idea of the clinical trial. That's the idea of the clinical trial is, can you take somebody on active surveillance and give them this particular medication and they stay on active surveillance? But we know right now that if a particular percentage of guys on active surveillance go on and get prostate. I've had patients of my own. They go on and, you watch them 2 or 3 years, and all of a sudden the PSA bumps, something happens, or the biopsy shows the spread, and now you got to treat those. What if we can keep those guys at Gleason 6 with a small, focus of prostate cancer that never requires treatment. How do you know that? One of these trials may tell us that. And that's the benefit of the clinical trials.
Thank you.
Sure. Yes, sir.
Okay. Now, on my sweetie, my wife, she got into this study by a group of African American women who were connected with Harvard Medical some years ago. And of course, she also gets compensated. That's another thing about these studies. A lot of them, you do get compensated, one form or another. So, So, as I look at it, I think we men should try to figure out some ways that we could make sure that we get more recognition into the studies. Like you as an assistant professor at Harvard, I'm saying, how many years have you been there as assistant professor? Unless you want to be just assistant professor, why aren't you a professor? Compared to how many other doctors who look like you or me at Harvard, I'm not trying to start trouble, but at the same time,
I mean, if I had opted to write as opposed to lecturing all over the world, then I would have been promoted higher. I just haven't done that. I do this, I do television, I do all this other stuff, and you don't get promoted for doing those things. It has to be written. And as far as payment is concerned, the only trial where they want to pay is the trial where they can't get people. If you got a whole line of people standing at the door, you don't have to give them anything, except a hello. Anybody else down there? I'm going to turn it back over to you. Thank you very much, guys.
Let's give Dr. Carter another round of applause for a great job. Our mission is to eliminate the prostate cancer racial disparity. We die at a rate 2.3 times greater than white men for prostate cancer. That's a big gap. That's 130% higher rate. Now, in order to do that, we have to find ways, things that work for us. We have to get diagnosed earlier and see what treatments are more effective on us in order to close that gap. And the only way to really do that is to become actively involved in clinical trials. I'm going to talk about two instances where clinical trials played or are playing a very pivotal role. Dr. Carter talked about the U.S. Preventive Services Task Force and the recommendation on PSA screening. We have dealt with that subject for a number of years now. And we know that in 2012, the U.S. Preventive Services Task Force recommended that no man should be screened for prostate cancer. It is something that we disagreed with. And we disagree with it primarily on the basis that we have a much higher incidence rate, we tend to get prostate cancer earlier, and we die at a much higher rate. And those were the basis for our arguments. However, when they looked at the clinical trials that they used to make their recommendation, as Dr. Carter pointed out, there were not African American men in those trials at a statistically significant level. There were not enough there. So they used the data that they had and made that recommendation. So in their upcoming upgrade, a review of that recommendation this year, they sent out a request that we comment on the draft research plan, and we put in comments that you should stratify the recommendation, one for average risk men and the other one for men at high risk. And we pushed that position, and they changed the research plan. But when they came back with the draft recommendation, they indicated that they could not find any data in these clinical trials for African American men. However, they did change their recommendation to now from an I to a C, and said that men should discuss with their doctors about screening for prostate cancer. So they no longer are saying you shouldn't have screening, but it should be a shared decision between each man and his doctor. The problem with that, however, was that they recommended screening began at age 55. And again, because there was no data for African American men or other high-risk men to change that age group. And so what we did is we went back with our recommendation that our comments that were due on May 8th, a few days ago, that their recommendation still should some way indicate that the doctor should inform black men and men with a family history that they should begin start screening at an early age. Now, that's really going around the bush towards trying to get to a solution where we think we might know the answer. I mean, all the indications kind of point to the fact that if we get screened earlier and treated earlier, we get prostate cancer at earlier stage, early age, and more aggressive. So it's tend to say that we should know about it earlier. But they will not make that recommendation because they're based upon, quote, scientific evidence out of clinical trial. So while we're pushing that position now, and we'll see how that comes out, that's an uphill battle. Clinical trials, African American men in those clinical trials, and that data showed that, yeah, there was some great benefit by starting screening earlier, so to get earlier treatment, that it saved lives, we wouldn't have this battle. But so in order, again, go back to our mission, to realize our mission, we're going to have to make changes like that and get men involved in clinical trials. So that's one example. Another example is today I received a call from a company, and I won't tell the name of this company because this will be made public this weekend at the American Urological Association meeting here in Boston. But there was a treatment that was approved by FDA in 2010, and we were heavily involved as advocates that this treatment be approved. And when we looked at the clinical trials data at the year that it was approved, it showed that black men had a much higher benefit in terms of survival benefit than white men. It was very clear, that it was much greater for black men. The problem was there were too few black men in that trial that they really could not say that officially. They could not say that, and so this may have been, even back in 2010, a treatment that could have saved many lives. But since they couldn't say that, it just continued to give it based upon the benefit for average white men. Well, they began a registry trial, and Dr. Carter knows about those. These are not treatment trials; these are registry. You collect data after the fact, and what it showed now with 12% black men in that trial, that benefit is real. That benefit is real, and that's a major breakthrough. And as I said, that will be presented here in Boston this week, and that's one of our partners, one of the pharmaceuticals that we work with. So we're excited to work with them. It may have some real benefit in terms of saving lives. So we began the clinical trials rally at the beginning of this year to really bring the message to you around the country, to all of our activities, to our webcasts, our symposiums, that hey, we have to become involved, we have to become knowledgeable and involved in clinical trials because it's in our best interest. We talked about the history of clinical trials and experimentation and atrocity. The atrocity today is that we're not involved. These things are happening without us. That is today's atrocity. Years ago, it was experimentation. Now, we're not there. So we have to correct that. So that was a long way around saying that we have to become much more knowledgeable and much more actively involved in prostate cancer clinical trials. So, does anybody else have any questions? Okay, now one of the things that I do wanted to point out is that Sunday is Mother's Day. Sunday is Mother's Day. We do a Father's Day rally coming up in June. But for myself and many men here, and many of those who tune in, you know, we're probably standing here because of the support of our wives, the mothers of our children, and our mothers. So I want us to remember our mothers and really treat them properly. Buy some beautiful flowers. We don't know, you know, the next round where we're going to need some more treatment, we're going to need some more support. So I just want to, from Finn, I want to give a shout out and thanks to all the mothers on Mother's Day. We love you and we thank you for all of your support. With that, I think we've done our business for this evening, and I want to thank everybody for being with us here in Boston. I want to thank all of you who have tuned in. I will say that, it looks like, do we have a question?
When is the next meeting?
The next meeting is the second Wednesday of June. Who has that date handy?
It's right up there, June 20th.
The next meeting is June 14th.
Thank you.
Okay, everybody got that? Everybody got that on the calendars? So thank you all very much. Again, thank you all for coming here. And
So for those that are watching online, you can next time email questions. If you have questions.
yes. We made that announcement at the beginning, and we want to emphasize for those of you who are watching online that you can email your question. You know, this is the first meeting where we have used Facebook Live, and I just looked at the numbers. We had approaching 5,000 views of this webcast tonight. Isn't that something? So we had quite a crowd, and this is the beginning.
6,000 now.
6,000?
Oh, wow.
6,000 views. 6,000. So let's give Eddie a round of applause. For all of you who tuned in for the very first time, please tell all your friends about June 14th, and we'd love to have you tune in again. Thank you very much, and good night.